So, good evening, everybody. Welcome to tonight's Health, Housing and Adult Social Care Scrutiny Committee. My name is Councillor Jane Burton and I'm the chair of this committee. We have one item on the agenda this evening, establishing a joint committee between City of York Council and the Humber and North Yorkshire Integrated Care Board. And we're asked to for a recommendation, if possible. Members are asked to note and discuss the developments in health and care integration and the opportunities, challenges and implications for the health and well-being of York residents. Before we go any further, there are no apologies for absence. Everybody's here. It's a full house, good. Declarations of interest. Has anybody got any declarations of interest? Nope. Okay, good. There's no public participation this evening. So we're going over to the main topic of the evening, and we have with us Peter Roderick, who's Director of Public Health, and Natalie Cafane, who is the Assistant Director of Systems Planning for the Humber and North Yorkshire Integrated Care Board. We've also got with us tonight Councillors Douglas and Councillor Steels-Walshaw. So welcome everybody. Welcome back to the first meeting in this new year, 2025. The minutes of the last meeting are not ready, so we're not going to have to pass those minutes. I've been asked by Councillor Rose if he can have a short amount of time to comment on a previous meeting's minutes, and I've said yes, he can.
It's just a very brief note, because we talked quite at length about the pharmaceutical needs assessment and the Clifton pharmacy situation back in the autumn and last meeting, but it's obviously not come through on the minutes yet because we haven't progressed it through. But obviously over Christmas, those who've been paying attention to the press saw the similar situation that we've had. It is fundamentally different, but the similar situation we've had in Westfield, where what's classified in the application as a no significant change might actually be a very significant change to not just that locality, but the kind of shape of the city on an out of hours basis. So for those who haven't seen it, the application is to take the Green Lane pharmacy license and move it to Cornlands Road, where Priory Pharmacy already exists. So there's a risk there that by overwriting or consolidating, in the words of the applicant, those licenses, you lose the license for the out of hours, which is the 72 or 100-hour license. And therefore it's at their own mercy if they continue to serve out of hours or not. So I just wanted to flag that as a similar issue in terms of our responsibilities, the benefits and risks of P&As and how much they're worth the paper they're written on, the role of the ICB and what they accept or feel obligated to accept under the law, and also how quickly we bring that topic back to scrutiny. So it's a bit work planning, it's a bit related to our working with the ICB, and it's a bit urgent business, but not enough for us to actually have a full discussion. And because there's no consultation open for us to submit a scrutiny's opinion into, Health and Wellbeing Board, I know, did submit a comment, but I just wanted to make sure scrutiny was aware of it and suggest that all parties at some point soon have a think about how we tackle the challenges around pharmacies.
Absolutely, and I remember it being a very productive meeting that we had about this. So yes, thank you for raising that again. So back to tonight's business, and yeah.
Chair, if I may, very sorry. I thought I might use that opportunity on the basis of that item to just let members know that we're actually have just released a consultation document on the next pharmaceutical needs assessment, which is P&A 2025. That will start being advertised and disseminated. So it's a chance to feed in. Obviously, it doesn't in any way, I guess, tackle the situation that's been explained this evening about the present one, and an application is currently in, but it's a chance for stakeholders to shape what we do put into the next needs assessment, which will influence these decisions in year to come. So I just wanted to give that opportunity to flag, and that is going out through the Public Health newsletter and on council websites. If it's not live already, it will be within the next few days.
Right, thank you very much for letting us know that. Okay, so over to our two guests today, Peter Roderick and Natalie Cafane, please.
Thanks, Chair. Well, I'm going to introduce this item and talk the committee through it. Natalie is here with me to give the ICB's perspective on it. We also have other members of the York Place Partnership, obviously, around the table. So I'm really hoping for a really helpful conversation this evening, and very much welcoming questions on our direction of travel here. What we're presenting is a decision that the Council's executive have taken back in November to establish this joint committee and to delegate to officers to sign a legal agreement, a Section 75, between the ICB and the council. And so Scrutiny are being asked to note this decision and to participate and take, I guess, a sense of engagement in the process that we are going through between the council and health in aligning the work we do to pay and buy services, health and care services in the city for the benefit of residents and to produce better outcomes. Obviously, the Scrutiny are going to be very interested in that and wanting to keep as engaged as possible within what is a bit of a journey and a bit of a process. So it's not a single moment in time. In 2022, the Health and Care Act was a reorganisation of the sector, and particularly the way in which services are bought and paid for, commissioning. We had clinical commissioning groups, and we had one for the Vale of York. They were abolished, and in their place, we had 42 integrated care boards, so much larger organisations than our previous clinical commissioning groups. And our ICB covers 6 places, one of which is the local authority of York. Within that legislation that created ICBs, there was always a mechanism for forming what was called a joint committee. And this was essentially that all ICBs had to have place committees. So you had to have one of your executive committees of the ICB, which was dedicated to a local authority area, one for each area. But those were essentially ICB parts of the ICB governance, so they were part of the health governance initially. In the legislation, however, it did allow for making those formal joint committees, where, as well as being part of the health governance of a local area, they'd be a part of health and council governance of a local area, and that is what we're moving towards. They are not, and our Director of Governance would like me to emphasise, they are not joint committees under the 1974 Local Government Act, and so they are not a previous form of sort of joint committee that members might be more familiar with. They are essentially health service versions of joint committees, and the way that legally they come together is through this Section 75 that I will explain. That's the sort of the legislative background. There's a bit about the why in all of this, isn't there? And at Section 20, the paper that executive approved, which is one of the annexes, is to your report that you've got today, sets out a little bit of the why, I guess what we're calling our sort of narrative about why we're heading down this route of joint commissioning. And we, in the end, want to absolutely focus it on improving health outcomes and the care and NHS outcomes for our residents. In the health and care sector, there are things that we can only do together and we can't do alone. We need to manage the markets in some areas of spending where we have multiple providers providing similar things. We need to support people who are out of area, generally back into a less expensive and better outcome in area placement. We need to address the rising number of long-term conditions which will have an impact on the council and on health. So if we think about something like dementia, or we think about people who have had a stroke, or we think about people with a severe mental illness, we know that they often experience care from the NHS and then care from social care and housing and other aspects of council services, where the join up between them and the integration is not optimal. And we want to make sure that if we're going to fund those services through different mechanisms, that those are really joined together. So section 20 gives a little bit of a sense of the why and the narrative. The mechanisms that we're bringing together are twofold. First of all is a joint committee, so a group of people who meet together monthly, and I'll come on to that. The first is this is section 75, a legal agreement that ties some of our decision making together. And although that sounds significant and some of the numbers financially within the paper probably appear fairly significant, we are talking, multiple millions of pounds, actually we already have a section 75 and have had so for a good 10 years, which is the Better Care Fund, which is reported as is in legislation to the Health and Wellbeing Board. So actually in our first year of operation, the amount of extra funding that will be covered by this section 75 agreement will only be marginally more than is in our BCF. It will be a significant increase, but it is essentially something we have been doing with health for 8 to 10 years with good governance around the decision making. Under sort of sections 27 and onwards, the paper sets out some ways in which those budgets are brought together, and essentially there are 2 different ways: aligned budgets and pooled budgets. Pooled budgets are essentially where in all but actual fact, but pretty much in practice, you have a joint bank account. You make decisions and spend decisions absolutely as almost as one organisation. And aligned budgets is a slightly weaker version of that, where you make decisions about how you spend, but that you go on and do the procurement and some of that aspects of it in a separate manner. And that we would like to see eventually covered by aligned or pooled arrangements, a range of different budget lines ranging from some mental health provision, some children's services provision around children who have significant health need, some public health funding decisions, some allocation and funding around what's called continuing healthcare and funding for people towards the end of life, and funding for older people and older people's care. That's the section 75. It will be a legal agreement that we will sign at the start of the next financial year, and it will essentially mean that when we decide to spend those funds at the start of each year, as a council and as a health sector, we are involved in each other's decision making. It will be formally taken through the second bit I wanted to talk about, which was the joint committee. And the joint committee is the group of partners who come around a table to discuss and sign off these decisions. A few things to mention here. First of all, the joint committee formally, and in the legal document we sign, will be between health and the council. So it will be essentially senior officers from both of those 2 groups making those decisions. However, that's what the legislation says we can do. We're mindful that we've had a place partnership in operation now for 2 years, which is broadly functioning really healthily and well, and has more than 10 different organisations represented. And rather than have the council and health sit in a room with the white smoke going up after a decision is made, our agreement as a set of partners is that we will run the joint committee, the formal decision making around some of this finance, at the same time as that place committee. There won't be 2 separate meetings. There are things within the governance about how you might vote when there is a need to vote on a decision, and the fact that at that stage it would be the council and health who are responsible for that voting, because our partners' money is not on the table at this point. However, for the vast majority of decisions, the proposal is that we will discuss and come to an agreement across sectors, including primary care, mental health, the hospital, council, our commissioners in the ICB, and actually including a university, education partners, a number of different partners too. So it's really meant to be real joint decision making. but with the safety and formality of the governance of when we need to vote, we actually know who's eligible because it's resources on the table. On the resources, we're not in any way changing budget setting processes around health and care. So our executive will propose a budget to full council every year, which will include the allocations for adults, children's, public health, and those envelopes will be used, those financial envelopes will be used for the decision making around some of these joint pieces of work. And there's a good history of this happening in many other areas. We're not the first area to go down this road, and we've got strong legal advice about how this is going to work. And also the other 5 local authorities in the ICB are all going down a similar route. North East Lincolnshire already has this in place, so that there is good sort of solid base on which to do this, to make sure that the arrangements are in place from a governance perspective. I'm almost finished with my bit. I just wanted to bring it alive in a couple of ways, just with a couple of examples. I'll shamelessly steal an example from our Director of Adult Social Care, who, along with our Director of Children's Services, is very closely tied into this work. And it's an example of a piece of joint funding for a group of people within the population in which health and social care are having to make a number of decisions very regularly throughout the year about who funds that care. And we estimate, just purely from a social care, so our council side, that we are devoting probably 2 days a week of quite senior management time and quite considerable administrative time into being able to get those decisions made and the right paperwork filled in. Similarly, the ICB will probably be doing about the same. And actually, if you look at the decisions historically, the funding has split almost entirely 50-50 over the last few years. So in some ways, coming up with an agreement about how we would pull that funding would release all of that time to make a claim against health should be funding or the council should be funding, etc., and all those transactional and frictional sort of costs. And you'll be able to use that time better to plan services and to support patients and residents. It's just a small example of how actually at the moment the system causes us to, in some ways, sometimes be slightly in competition or rubbing against our health partners. And actually this is designed to remove that. Second example I will give is of some work we've already been doing around prevention and health inequalities funding, together with our health colleagues. Over the time period we're planning, it's not a substantial amount of money, it's probably around £2 million-ish. And we've started already planning what that funding will be allocated to and doing the work on that, absolutely lockstep with our ICB colleagues. And as well as part of that, a co-design process with a group called York Health and Care Collaborative, which is chaired by a Director of Housing and Communities in the council and a local GP. It's got multiple partners on, probably upwards of 30 or so partners from across the system who have been involved in designing how we might better run a prevention system in York, that low-level early intervention and prevention, and tackle health inequalities in the process. The ICB and the council are writing together now the paper that proposes where those funding streams should go. It's going to the healthcare partnership at the end of January for the partnership to sign off where the funding should be allocated in almost a sort of a test and learn shadow way, because that's how we will start doing things from April, but we're trying it out with this particular piece of funding. And I'm hoping out of that will come a really well-designed piece of work where the partners have all been really involved. We've not commissioned separate things which duplicate. We've not overridden each other's work, but we've worked in a much more aligned way. So just a couple of examples to bring it alive. I'll hand over to Natalie, who's going to talk a little bit about the ICB's role within this.
Okay, there we go. Yeah, so the ICB's operating model sets out kind of 2 different ways of managing health resources. So one is the sort of acute inpatient care, planned care pathways, mental health inpatients. So there are things that will be delivered across the ICS's footprint by collaboratives, and there are services that will be delivered at place. So community primary care will be delegated to place. So this is the kind of resource we're interested in talking about here. The setting up of a joint committee in York preserves and formalises that local decision making based on the needs of the population for a significant proportion of our health resource. So working together with the local authority in this way means that we're not making decisions based on our individual organisations and between health and local authority or around services. We're making decisions for population in terms of their holistic needs as people, because people have contacts with various different services through their time. So we can't be seeing those in isolation and making decisions based on one service or organisation. The approach, I think, builds on the strength of leadership across the York system, across the York health and care system. And for us in health, one of the benefits is that it leverages the community insights that local authority and other partners around the table will have. It allows us to bring all that knowledge and insight together across York. There'll be areas where joint commissioning makes sense and reduces duplication and makes best use of our limited public sector resource. And these are the resources that we'll be putting initially in the first year. Focusing in the first year, most of the funding will be around discharge schemes, urgent care schemes, health inequalities and prevention. So there are areas where we can see the real benefits in the short term. Longer term, this development is really in line with national direction around moving to more preventative care, moving away from hospital care and into community settings. So working together on that is really key to doing this and how we deliver this in York in future. As Peter's referenced, the ICB is entering into similar arrangements across the Humber and North Yorkshire footprint. So there are 6 places, one of which North East Lincolnshire has been working in this way for several years. The other 4 places, Hull, East Riding, North Lincolnshire and North Yorkshire, are looking at putting similar arrangements, joint committees in Section 75, with some new ones because there's some sort of tailoring to local need and how some of the kind of details of how things will work are slightly different, but across the patch the ICB is doing similar arrangements across all places. That is all I wanted to pick up. So.
Thank you, Natalie. I think back to you, Chair, for questions.
Sorry, yeah, thanks very much for that. So I would like to take questions, please. Councillor Rose, Councillor Runciman and Councillor Cook. So
Thank you very much.
I'll note that down. Yeah.
Thank you. Thank you for the paper and I mean, I think it goes without saying almost that it's a really good initiative to try and bring ourselves closer together, and there's a lot of really good stuff in here about how it takes what we already do well and build on that using recent legislation. I've got quite a lot of in the details of the specific risks and stuff, but a quick one up front is obviously in parallel to that, we've had a general election. We've got a government that's talking about more integration of services, healthcare, social care, etc. And I just wondered if you had any insight collectively, and perhaps Claire as well, around what might be changing and whether this is what the government has in mind for local councils and ICBs, or whether we're going to be seeing something in parallel trying to emerge and this is more of an interim approach.
Happy to kick that off, and I'm sure others will have comments. I mean, not party to any special insight into any of that, Councillor Rose. I think a couple of things I would mention. Natalie mentioned that part of this is about the shift from acute to prevention, and there are 3 shifts we know that will be in the health plan, and that is a key one. And this definitely enables that, or we hope to design it to enable that. One thing I didn't mention as part of this, but it probably, given that the model was approved in December, it was probably a little early in this paper, but I think it is important at this stage now to insert within this piece of work our move towards neighbourhood working in York and an emerging neighbourhood model, and what that might deliver in terms of benefit for residents, but also the fact that a lot of the funding streams which pay for neighbourhood workings have, until this point, been a little misaligned. There's good examples of contracts in which we should have probably have done work to make sure that organisations who are commissioned by health and care actually that those contracts say similar things and work to similar objectives and don't have organisations going off in opposite directions. So that probably lies at the heart of the neighbourhood model. We're going to need to commission well for that. And we certainly know, and I'm picking up in terms of some conversations I've been involved in with the LGA around the 10-year health plan, is that a neighbourhood model will be at the heart of it. I can't really see any integration direction that's been in those conversations that is sort of out with anything sort of outlined in this paper. I mean, as with health, and we probably all sort of with a wry smile will acknowledge, health structures do change quite regularly. But some of the core principles you can build can survive those changes. And North East Links, I think, is a very good example of that. And, you know, I'm sure North East Links, you know, their model would, you know, might have its detractors, but they've had integrated commissioning since the days of CCG. The move to ICBs probably knocked that a little bit, but they built back quicker and have established their joint committee quite a bit before other areas, and already have a lot of the provision. And in the end, the commissioning is important, the funding's provision. In the end, what residents care about, I imagine, is the delivery of the services and the provision. They've built the provision around funding streams which work, and the provision has maintained its sort of its delivery when the commissioning is thrown up in the air by restructures. So that's, I think, what we've got to do with this is we've got to change the way frontline professionals are working, enable them to do so, and restructures and changes to policy will follow and hopefully be helpful. But this, for me, should enable some better joined up working and delivery, which very much I'd say is in line with what I'm seeing from sort of future government direction. So that's my take. There may be others who want to comment.
Okay, thank you very much. Councillor Steels-Walshaw.
Sorry, just to follow on from what Peter said about the neighbourhood plans and aligning with future directions and around the Darcy report, and it does align with kind of the 10-year priorities that are in the Darcy report, with the neighbourhood model at the heart of this, with early intervention and prevention, which it makes very, very clear is what we need in communities, what we need to address, and how we're going to change by responding to the needs of those people there and making these changes.
Okay. Thank you very much for that. Councillor Runciman.
I think this one's for Peter. Peter, given the number of committees that report to the Health and Wellbeing Board, do you feel that there will be any overlaps? And will those groups have to relook at what they're doing to make sure they're not duplicating?
Thanks, Councillor Runciman. And yeah, happy to answer that question. Obviously, with Councillor Steels-Walshaw here as well, in terms of chairing that board, we can probably both input on that. I mean, we've done quite a bit of work over the years with the Health and Wellbeing Board and its terms of reference, as you know, Councillor Runciman, and we've had long conversations about exactly how some of the health partnerships that have been actually in place prior to this place partnership and the Health and Wellbeing Board best fit together. I'm really clear, as you know, as part of my role as DPH, Health and Wellbeing Boards are statutory boards. They're in legislation. They have a quite clear statutory function, and I'd probably emphasise a few things about the boards that I think we ought to bear in mind. A Health and Wellbeing Board has that duty to produce the strategic needs assessment. So essentially, what is the need of the local population from a health perspective, and a duty to write a strategy of how we improve that. And we, in 2022, wrote a very ambitious 10-year strategy, which had some really long-term and long-range goals, which were developed cross-party, cross-sector, multiple sort of partner engagement. And for me, that very much forms the core of the Health and Wellbeing Board's business, and will remain so until and if legislation ever changed. But at this stage, that's what the board does. And as part of that, I think we've always recognised that the clue's in the title. It's health and well-being, and actually the power is probably most often when the board is talking about the wider determinants of health and many of the use the word with caution, but I guess the lifestyle and aspects of the health of the city around smoking, alcohol, obesity, all that sort of thing, as well as economy, housing, those types of things, and absolutely has a role as well in making sure that NHS partners play their role in the health and well-being of the city. What the Place Partnership has been doing and will continue to do is a lot of the in-depth work around funding and quality and assurance, and some of that is probably better placed in those types of settings. And the mechanism that we've created is that the place board, and it's quite a use of time. Councillor Steels will sure agree, but we devote sort of 20 or 30 minutes every single health and wellbeing agenda to the place partnership, which may feel like duplication, but for me is actually about saying the place partnerships work is all about the NHS and how the NHS and care are integrating and how we deliver good services. Health and Wellbeing Board needs to know that that work is happening, have good assurance, see some of the outcomes, see the minutes from those meetings. But it also needs then the rest of the space on its agenda to talk about those wider determinants of health that the place partnership probably isn't focusing so much on. So I'd see them fitting together, and that's certainly within the 2022 legislation is the way that they were cast within the guidance. Place partnerships won't write JSNAs, they won't write health and wellbeing strategies, they won't be able to take that really wide approach. And for me, that is the strength of what happens around the Health and Wellbeing Board.
Okay. Thank you very much. And Councillor Hook.
Thank you, Chair. My thing's a little bitty more technical things because I got quite confused by some of the stuff in this paper. I like the misprint about the Health Can Care Board in that grey section there, and or mistype. And paragraph 23 got very confusing because it says that the Health and Care Act, section 675Z, whatever that is, allows for the formation with an integrated care board in any local authority. And then it says you can do it. And then it says local authorities are not relevant bodies. And yet before it said the local authorities were the one it was designed for. And then it goes back and says it can do, it's a means of doing it. So I just got totally confusing at that point. So some of the mechanisms I think need to be, well, I don't know, sorted out or made more clear. I really support the idea behind it because I work from the rail industry where you had a whole army of people work from the train operating companies and Network Rail who were really well paid and arguing who train delays were responsible for and who had to pay for them. And that was totally unnecessary, really, as far as I can see. And that echoes in this. So I'm totally supportive. You mentioned the Better Care Fund was our original thing. Does that mean that's going or if it's gone and I've missed it anyway?
Yeah, I'll answer that question. So no, it's staying, absolutely. A Better Care Fund is still a mechanism, still reports to the Health and Wellbeing Board in terms of its formal governance. It will now also, and it is able to be included within this type of Section 75 arrangement. So it essentially is an incorporation of one Section 75 into another bigger one. And in answer to Section 23, apologies if is that not hugely clear. My public health training was mainly bugs and beasties and infectious diseases and not legal terminology. So I want, without passing the buck to legal colleagues, quite a lot of this has gone through those routes, and I am assured that those are the right words, if even not hugely clear about what they mean. And yeah, we certainly. In terms of the way the BCF will be governed, we are not proposing any huge changes to that. Some areas chose to put a lot more money into their BCF over the years, and that in some senses is a little bit what we're doing here. It's just as part of that, the governance wasn't as wide and as robust as this needs, and it didn't tie people together in a joint committee. So this is probably the direction of travel now, rather than putting more money into BCFs. I think most areas are probably now doing this instead.
Well, thank you, Chair. Thank you for that introduction to the report. I think it is quite interesting. I think ultimately what matters is sort of residents actually feeling improvements. And having got a few friends and family in North East Lincolnshire, I'm not sure they'd say the actual outcomes in terms of what they experience on a day-to-day basis is a sort of ringing endorsement of the health structures there. However, my question is actually on paragraph 50 of the report in terms of the consultation or lack of consultation. I think it's something sort of Pravda would be quite proud of. I'll just read it. The specific matters in this paper have not been subject to public engagement as they predominantly reflect the changes in our NHS and local government commissioning architecture. The ICB legal team have advised that there's no statutory requirement to carry out a public engagement for the establishment of a joint committee and to sign a Section 75 agreement. However, the CYC and the ICB fully intend to engage patients and the public on the benefits of integration between the NHS and social care more broadly. I'll stop there. I mean, that's not. I appreciate the sort of decision to not have a consultation. That's perfectly sensible, given you don't need to. That's fine. But I guess it's the sort of, we're going to tell people how brilliant this is as a sort of method of consultation, which generally isn't something I guess local government is used to, and particularly given the sums of public money involved. So I guess 17.2 million of ICB funding, 8.2 million of CYC funding. I had a glorious 4 years and responsible for about £5 million of CYC funding, and we wouldn't spend £100,000 without consulting the public on it, let alone 8 million. So it was just, I guess, the decision making behind that. And I would agree with Councillor Clark. I mean, this is complicated, and I think generally, the sector generally sort of enjoys a certain opaqueness. The structure's already complicated, and then we talk about it in a language that further complicates it often, when actually it's relatively simple in terms of a pound goes from this taxpayer to this staff member. It's not actually that complicated as a structure. We just we cloak it in a language that complicates it. But I guess my question really is on paragraph 50 and the conversations that have been had between CYC and the ICB around deciding to go down that avenue.
Thanks, Councillor Smalley. So a few responses on that line. The report does go on to say that I guess the direction of travel, what we're aiming for, what the Humber and North Yorkshire system is aiming for, as in its partnership plan, was subject to partnership consultation, and of course our health and wellbeing strategy was subject to consultation, as are our budget proposals. So that I would point to elements of consultation which I guess hover around this piece of work, which are quite extensive. The values and the amounts and the decisions that are taken each time will still be retained through governance structures. So for instance, if new resources wanted to be committed by the council to this, which would go through this mechanism, it would need to do through democratic routes that it already has, so that there are those safeguards there. The key, I guess in many ways, the report sets out the wiring of how we're going to make sure funding flows in York to get to the right people who deliver care. So if a GP wants to employ another physio, that decision would need the funding to pay for. If the hospital wants to open a new integrated care team which works together with social care around comprehensive geriatric assessment or something like that, again, that would need the money. And the report is about the wiring, about how that money were to get to the right places. And in that sense, a lot of the consultation has not been your formal public consultation with surveys, that type of thing. But as we've listed in the report, we have these partnership structures with all of the partners, the third sector, our GPs, our mental health providers, and council and ICB representatives who have been very closely involved in designing this, as well as the York Health and Care Collaborative. As I mentioned, it's a big group, over 30 people. It has a number of people with lived experience so people with experience of health and care that are there as lay members or lived experience members. So actually, as we go through, there is a lot of involvement in people in many of the decisions, but you're absolutely right. The report does point to the fact that we're not proposing a full-on public consultation for this move. It's been taken through the democratic process, and decisions been made at that at this stage on that.
Thank you, Chair. One of the things that I found when sort of researching this paper was about how Warwickshire ICS have collaborated with Warwickshire Fire and Rescue Service, and they've been working with them on their frailty hub. So I just wondered, while we're sort of in the process of setting this up, whether we could look at working with those colleagues on a wider basis. They've seen really great results. I'm happy to share the link around, but I think that's really exciting. Lots of local organisations who know their areas really, the local area as well, working together and getting good results.
Thank you. I very much take that idea back. Obviously, we've got opportunities through the new combined authority, fire and rescue, as part of that to take those conversations forward. I think it's a great idea, and certainly the safe and well checks that fire services do are really helpful and really expanding beyond your sort of smoke alarms and fire prevention stuff into encouraging, spotting the early signs of dementia and thinking about vaccination messages in the winter and that sort of thing. There's absolutely more we can do with that really wide workforce around health that I don't think we fully pull on in the system. So I fully agree, and I'm happy to take that away as a comment to feed into some of the people planning this.
Thank you, Chair. I've got two questions, basically. The first is about bureaucracy, and the second is about aims and outcomes. You've both been very clear about the desire to reduce duplication, and that's a laudable ambition, and I don't doubt you have it. How are you going to measure that so that when you come back next year, you can demonstrate that what has happened in this new arrangement has resulted practically in a reduction in duplication and a freeing up of staff to do other things?
I'll let Natalie go first, and I'll come in afterwards to give you a chance to say something.
That is a very good question. There will certainly be some work around the things we can do jointly between our teams. So we've got examples where we've got posts working across health and social care, and that reduces duplication in terms of their work. And so that will be easy to measure, and that will be easy to see. The challenge will be how we measure that in changes to services and integration of services. And I think that's something we'll have to consider up front as we take forward all the developments that we will do. Each part of the partnership's work plan we'll need to consider that upfront. I don't think there's a one-size-fits-all approach to that. I don't think we can say going into this we will measure it in this way, but it's certainly something that will be considered by the partnership in each of its pieces of work.
I mean, I'd say they're probably a 1 year time horizon is fairly ambitious for some of this stuff, but let's, if we take sort of 10 years and we think about some of the really common integration-based problems that we might sort of be able to measure. So one might be what is often talked about, kind of the garden path syndrome, where the district nurse sort of leaves the house saying hello to the care worker coming into the house, which has been typical of sort of health and care integration over the years. And it's a bit of a caricature, I'm sure, but I think so a simple metric I might give you there, and it's a bit of jargon, but the number of multidisciplinary team meetings that are held in York between social care, mental health, primary care and the hospital, particularly around some of our frailer or more vulnerable residents, where care plans are owned by a single lead professional, and stories are only told once, and that care plan is able to be viewed by all the different professionals. That would be, for me, an example of integration that would deliver real tangible benefits. And I guess we have to always bear in mind with all of this that unless we do some of this, we know the costs of this are spiraling beyond what those which we're able to afford as public authorities. So we have to, you can't in some ways show the benefit of reducing management costs to a resident, I guess, unless you introduce that concept of opportunity. We use the money that we would have been spending on management to provide for the frontline services. So that's very much what I'd hope from out of this. Another example would be that we just know that, and this is not a York issue, it is a national issue, that people have such a battle around the funding of care around continuing healthcare. So whether health pays for a package of care which is primarily health, the reason for needing the care is primarily health, or whether it's primarily a social need. And we know that one of the things that results in is just very long decision-making processes. So length of decision-making process, especially when people may be towards the end of their life and every month counts. So just some tangible things. I wouldn't hold myself to any of those metrics and haven't put them in the paper because they are notoriously difficult to crack. But if you were looking to see if this worked over, possibly the 3 to 5 year window, you would be looking at length of CHC assessments, more multidisciplinary teams, more care plans that could be seen by more organisations. Metrics like that, I think, would be the things that you'd look to see sort of as quality markers for this. I don't know if that totally answered the question, but it was where my thought process went.
I will just chip in an example around the frailty hub that we've got set up in York, and the multidisciplinary team there, when we did comparisons of the time and the resource that was spent with those patients resolving the crisis that they were having at that time, compared to what would have happened before that integrated team was put in place. It was something like 7 hours for one patient for one episode. So that is freeing up a range. So it's ambulance technicians, it's GPs, it's a whole range of professionals, it's social care that are freed up to put that resource into other patients and to other care.
And I think part of the point of this paper is it is tremendously technical, isn't it? And it's a vehicle for actually, at the end of the day, as has already been said, trying to make sure that those people who need health service or care service of any type get it sooner and in a more effective and efficient way than they are at the moment. And it brings tangible benefits to them. So I'm sure over time that you will be asked to measure some metrics to show how this benefits people, and I think that has got to be one of them, hasn't it? Do people feel better about the care that they're receiving, or how do they rate the care they're receiving? I suppose they don't know what would have come previously, do they? It's interesting though, I know in North East Links that there has been concern that it hasn't delivered those benefits, but I think if we're serious about this, we have to find ways of making sure that it does, and if it's not, then you have to adjust and change. There's no good carrying on with something that doesn't work, essentially, is there? So I think that would be a really important part of the process.
If I can respond to that, Chair. I hear everything you're saying, and I understand the ambition. In business, if you want to achieve a change, you set annual targets, you measure your performance. At the end of the year, you demonstrate whether or not you've achieved something, on the basis of the old cliche that you can't manage what you don't measure. And we all share those same desires to see services improve. But unless we have a set of metrics, we'll sit here in a year's time and in 5 years' time, and all we'll know is that we changed a lot of paragraphs and had different kinds of meetings, but we won't be able to prove to ourselves that we delivered something. So that's why I raised that issue. And I personally would very much urge all involved to try and pin down some metrics that help us gauge whether we're performing. My second question, if I may, Chair, is related to paragraph 45 in the report. And this must now be the 4th or 5th time in a scrutiny committee that I've said something similar to what I'm going to say, and it frustrates me. But in the preamble to this, the report says, the report states the formation of a joint committee is fully aligned to the council plan and reflects the ambitions contained within our 10-year strategies covering climate, health and well-being, the economy, and so on and so forth. The first in that list is climate. But when I look at the aims and outcomes in paragraph 45, the climate doesn't appear anywhere in it. And that really matters to me, because if we have a 10-year strategy, then the climate has to be in there. And when I read at the end of the report, there are no climate implications. We all know that's not true. We all know, for example, that delivering services to rural areas currently involves people getting in cars and driving all over the place. And we could make the same arguments about mental health care provision and adult social care and so on and so forth. So if I have something to propose, Chair, it's that that list of aims and conditions should add the mention for the need of the Joint Committee to ensure that all its actions factor in and contribute towards cutting carbon emissions as one of that list, so that it helps steer those decisions rather than enabling us to duck them all the time. And I know all of us around the table care about this. So I would just very much urge, if that's okay with you, Chair, that we make that recommendation. And I'd very much like to hear what people think.
Thanks, Councillor Vassie. Absolutely take that point on, and we can look to add that to the list. So I chair the Health and Climate subgroup of the York Climate Commission, and so I guess very much feel in agreement with the points you make, and very much sort of concerned about the fact that I think the NHS at the last count is upwards of 5% of UK carbon emissions. We know it's a massive part of that link between human health and planetary health. And just to, I guess, reassure the committee that whilst this paper, in terms of some of the governance and the wiring, hasn't noted any climate implications of changing our governance and wiring, there are absolutely climate implications of the way in which we run health and social care. Perhaps with a little bit more imagination, I might have put in this paper around some of the issues you raise in terms of mileage and travel to give care, and the ways in which we might work together to improve that. But to reassure that, thinking just singling them out, York Trust do have a very robust climate change plan, which has got lots of actions in about NHS admissions, anaesthetic gases, inhaler emissions, travel to work planning. It's not perfect. No trust is perfect. They are big, often organisations with quite old estate that is quite climate heavy or carbon heavy. So, but I would say that the partners are having quite strong conversations about that. And in fact, the NHS has had a very strong sustainability unit and strong sustainability targets around carbon reduction for a number of years. I think your point, and absolutely would need to reflect that, is how we make this work to take that further. And so we can take that back in terms of a list of outcomes that we are essentially aiming for alongside the rest of the public sector decarbonisation and other climate measures to be alongside the work that we do here. So I'll take that away.
Thank you, Chair. Thank you, Councillor Vassie. And I wanted to assure you as well, this absolutely has been discussed. We've discussed it as part of the neighbourhood plan, also about how people having services closer to themselves, closer to them, health services, but not just closer, places that are on walking, cycling, public transport links. So I want to absolutely assure you that that is being looked at as well.
Thank you. And just, Chair, it seems like there is an agreement that that should be included in the list of aims, and I hope that that may come. Thank you.
I've noted that. Could I also just say something, because on page 21, it's talking about enable communities to shape, participate, take ownership of their health and wellbeing services. And I've written, does that include chemists and pharmacies? Given what we spoke about in the meeting, where we were concerned about what was happening in the Clifton ward, and now Councillor Rose has raised issues about what's happening in his ward.
If only a paper like this could solve all these issues. And unfortunately, I'm afraid that disappointing news is that Natalie mentioned the sectors which this covers. It covers community services, it covers social care and public health and children's services from our council's perspective. It brings in aspects of housing, supported housing, things like that from our perspective. And then as well from a health perspective, it does cover primary care. So in that sense, I think the extent to which pharmacy is obviously part of the primary care family, we could look to make sure that some of the concerns of Scrutiny Committee are raised through that, and we consider pharmacy. Unfortunately, the contractual mechanisms for pharmacy, even though it is technically it's a primary care service, and that's the kind of bit of the field that it falls into, are a bit different, and the pharmacies, as we've heard before on previous occasions, independent businesses that run under contracts from integrated care boards, which are kept quite separate to other parts of the integrated care board. And Natalie might explain better, but integrated care boards have to be run with some firewalls between bits of them. And the team that Natalie works in, and my colleague Sarah Compton-Lovell, who's the Place Partnership Director, is not the team that commissions pharmacy. But I think the influence that we can use around pharmaceutical provision is probably needs to be noted by from this committee to take back into the Place Partnership.
Yes, because we did give quite a lot of recommendations, and we thought the situation was really far from a great situation, to be honest. It seemed a bit ludicrous at times. So I just thought I would mention it. Can we add that in? It would be great. Okay, sorry, I was being a bit cheeky there, but we're on that page. So Councillor Moroney, please.
Thank you, Chair. As things stand, I'm afraid I have 3 questions. So I wonder if I could cheat and split the first one into 2. So referring to paragraph 10, if I may. Oh, sorry. Thank you very much for the report, which I found really helpful. But paragraph 10, I wasn't entirely clear whether the 10.5 million was new money or merely reflected the greater scope. I wonder if Natalie would care to address that.
So it's not new money, it's existing ICB resource, but it would be new into a Section 75 agreement. So it's on top of the existing pool budgets through the Better Care Fund. It's resource that sits in the ICB but is not pooled at this point.
Thank you very much. And if I may, part B, given the fact we've got 6 places and our council is renowned for being very poorly funded per head, either at the bottom of the league or near the bottom, depending on definitions, I'm seeking some reassurance that the allocation of these resources is equitable.
Okay. So the allocation of resources as it stands is based on the historic allocation across CCGs. The allocation formula is set nationally and is indicated to ICBs. What the ICB needs to work up is how it will allocate growth and new money across places. That has not been set out yet. That is underway, and that will be done alongside these developments.
If I might add to that, there are certain things I can say that Natalie can't. No, bit sort of further. I think just to say that question, I think, for me, it further strengthens the need for the work that is explained within the paper, because, Kaz, you're absolutely right that York has often received a very low allocation of funding in all public sector areas. So on aggregate, it leaves us very, very much having to run things in exceptionally lean ways on shoestrings. The ICB is going through a process where the game that's in town, as it were, is either, as Natalie explained, if it's about acute stuff, if it's about operations and people admitted into hospital beds for long periods, that very much will be decisions taken by these big collaboratives, and there are 5 of them, I think, at last count: a mental health collaborative, an acute care collaborative, etc. If it's about essentially or out of hospital things, but also urgent care and our social care things, the place committee will be asked to take those decisions. And then the place committee will have, from my perspective, and I've certainly, they'll have a sense of fighting for York about it. ICB colleagues won't necessarily be able to be that sort of specific, but I certainly will as Director of Public Health. I'm looking to make sure that the resource that York needs as much as possible is there from our health partners. In the absence of the committee, we don't have even the structural mechanisms to be able to do that, because this is the way the ICB will be managing their arrangements. So the question almost raises why part of this work is quite crucial, to make sure we do have the right governance to fight our case for our citizens, to make sure that they get the funding that we need to run services.
Thank you. Well, I did, but they're not strictly related to that, so I'm happy to step back and let somebody else come in, or I can carry on if you wish.
Carry on.
Well, that's very kind. Thank you. Okay, so the second one is, it was really good to see in the report, and also in Peter's verbal introduction, the emphasis on transferring refunds from acute to prevention. But we all know that secondary care tends to suck resources remorselessly. You know, we've had cameras on in A&E recently. How will this help to change the tide?
So I'll speak to my experience of this, because Councillor Stills-Walshaw and I sit on the place board, and it is the coming together, as Peter's already explained, of many partners across the board, and part of that is the trust, the hospital trust, and so we have these conversations month in and month out, and no, it is not easy at all, but there is very much a commitment, I think, from all members within that board, and the recognition that that preventative work is absolutely crucial in order to move us from where we are now, i.e. all of the money is pretty much going into hospital care, and in the meantime our population doesn't get any I wouldn't undermine the work that Peter's doing, of course, but is struggling to get healthier, and in some cases is not at all. And so there is no underestimation of the challenges that there's going to be in actually coming to this position of shifting money from acute care into preventative. But this joint committee, in principle, provides that first step to say, right, we've got the vehicle now come and put your funds in here and support us to stop people needing to come through into A&E as regularly as they currently do. And we're getting very good mood music, but some of those metrics that Councillor Vassie mentioned over time will need to be looked at, and I don't think this will be a quick process, but I feel quite optimistic that this is the best example of how we might start to do that we've had for many a period of time. And I'm going to embarrass you now. I don't know if everybody understands this. Likely you two should, that Councillor Moroney is an ex-GP, so he knows what he's talking about as well. And so, yeah, I think it's a good start, but time will really tell, and the health of our population will show that as well, won't they? And that's over a long period of time, isn't it? And something that I really mention very regularly is I don't think there's enough focus on children and young people's health within the place partnership at this point in time, because if we're truly investing in that early intervention and prevention, that's where we need to invest, and you know that really needs to ramp up as well. So I'm a big advocate for that. So does that land you two in it in any way, or do you want to add to that?
Not at all. Really endorse all of that. You know, fully recognise that we do have some population changes which are very hard to turn around quickly. And for instance, we know over the next sort of 15 years, as a city, we're going to go from 1 in 6 of us with a sort of chronic long-term condition to 1 in 5 of us, which is a massive increase. And And so those conditions often lead to hospitalisation, and the acute sector is there for those who need it. And we're always going to need hospitals, and the staff in our hospitals do incredible work. And actually, our hospital also has a lot of community services as well. So the boundaries are sometimes quite blurred, actually, because it might be that the hospital as an organisation doing more work in communities, in clinics, in communities, and in people's homes, district nursing and community matrons, for instance, are in people's homes, would be a good example of where we're absolutely shifting care out to the community. It doesn't necessarily mean that the organisation's budgets will necessarily change, but we'll be asking them to do more. And we've got to do that because, quite simply, that hospital site will not be able to cope with the increasing population and the increasing number of sick individuals. The best estimates, and I'm taking this from the neighbourhood model paper actually, which went in December to executive, is that we'll need an extra 7 hospital wards over the next 10 years in York. We don't have space for that in the hospital. The hospital's got no way of coping with that. And so we've got to find a way to do absolutely everything you agree with, and fully endorse the idea that you've got to start that journey very young. Health is very much determined, first of all, in the first 1,001 days, and then in the first 18 years of life. Investing in those things and then being able to shift care to the earliest possible point in a pathway in order to make sure that someone's years lived in ill health are as few as possible. Those years have been increasing. We've got to squeeze that and make it lower, is the way that will save the NHS and save care and be able to cope within our resources. It's a really tough challenge. I can't promise that doing the governance and funding of it in this way does all of that. It's like a 1,000-piece puzzle, and this is maybe 5 or 6 pieces of it. And hopefully the committee gets other updates and other bits of information on the other bits of that puzzle.
Thank you. Pushing my good luck into my third question, if I may. It's a short one, but the answer may not be short. We know that the NHS is immensely complicated and frustrating, or can be very frustrating. And we know that councils can be rather complicated and frustrating at times. And we're talking about pulling these organisations ever closer together. Now, you mentioned the really good work that's been going under Section 75, for several years. But is there any new resource allocated to actually managing this process?
I mean, the disappointing news is this paper doesn't set out new money that this governance unlocks. So, I mean, I might use the example of another sort of piece of joint work that we've been heavily involved in, which is devolution over the last few years. That came with resource that having a combined authority in some way unlocked, and it's not the same for this. I think Natalie's points about allocations still stand, however, and my points as well, that there's lots of money in health and care, and having these types of robust arrangements are the best way that we make sure that York gets its fair allocation. But unfortunately, as part of this, it is not that the ICB, when we sign this, will be putting in considerably more finance. We are trying to govern and use best the finance we have in a more optimal way. Natalie, is that a good, unless Natalie has come with some extra resources, even if she hasn't told me about it.
I'd love to tell you that I do, but no, I absolutely agree with that.
So does that essentially mean resource gets pulled out of other work streams?
The resource is effectively the same. What this does is moves it into an environment where we all make decisions together against it. So there won't be resource taken out of services and put elsewhere immediately. This is just about how we make the decisions around that resource.
Call a halt to your questions now, if that's okay. They're very good questions, they were too. Can I just say it's that we've got 20 minutes until 7 o'clock, and our guests have to leave at 7 because they have other commitments. So if I'm going to call you to speak and you've already spoken, could you keep it as brief as possible, please? Because I have got a few repeat people on my list here, and I've got 5 more people to speak. So just noting that now. Okay, Councillor Rose.
Thought you might get to me first. Yeah, let's see how brief this is. I've just had, because I've had about 50 different things going on in my head. I've just had to try and write it out. So I haven't been rude. I've just been sort of turning it into a shorter speech. But yeah, thanks to Christian for raising the climate stuff, which is obviously critical. And there are lots of improvements we can make. For example, Peter raised multiple cars going to one house as one easy example of that. Just one quick point on Peter's positive talk around the hospital trust environmental plan. Slightly cautious of my two hats, as I'm also hospital governor in a councillor capacity. It's definitely more ambitious than the other institutions, but I did raise concerns at our last governors meeting that it's not ambitious enough. It's already slipping, and it's slipping because of solvable logistical problems. So I've got an ongoing conversation by email around some of that, hopefully a public meeting on transport. But it's definitely an area where we could cross in health across the city, across all partners, and hopefully the Health and Wellbeing Board strategies and joint committee ownership can tackle that. So I think it's definitely something to include on the objectives. I won't ask a question to save time, but John's point around ICB funding is adjacent to a concern of mine around the fact that we've got differing geographies, and therefore how the ICB works with other areas might then lose some synergy if it's different to how we're operating while we're getting synergy there. So I think it's something to be mindful of, even though there's no, I'm not asking for your thoughts on that, but it's something for us to be aware of as a risk. I slightly agree with Anne's point around some of the details in the paper not being 100% on. I think, without sounding too odd, S65Z5 is correct, but S675Z is incorrect. But it's more of an exec paper than a paper that will come to scrutiny. So it's kind of full of technical details, and I think that the consultation points that Darragh raised are fair. The point I want to particularly focus on is sort of the opposite of Darragh's and Christian's points around outcomes. Obviously, outcomes are really important. I'm certainly not the Lincolnshire expert that Darragh is, but and then the new structure allows bad decisions to be made. That is a possibility. But I personally think outcomes are fairly guaranteed to improve under this. My concern is the flip side, which is obviously the other half of us as councillors, is about our risks and responsibilities. The ICB have their own risks and responsibilities. Some of them are unique to that organisation, and there was that talk around the sort of, I guess, competing ideologies in the past. That still sort of persists when we've got pooled resources and decisions, but only one of those two partners has that responsibility in law or in our structure. And I think that ties into the point John just made around resources and the answer around sort of making joint decisions. We've got that push-pull, the reliance on trust rather than it being enshrined how that split works. It's sort of two meetings in one, but not really. So the questions for me is all around what happens if there's not agreement between the council and ICB? What happens if the place board partners don't agree with the joint committee decision while it's being made in a sort of joint meeting? That sort of area, how do we manage those risks to make sure that we as a council and councillors are confident that committee isn't going to end up making decisions that risk our responsibilities in favour of ICB responsibilities?
Thank you, Councillor Rose. So, yeah.
The long version was doing that without a script.
Yeah. Right. Okay. Can you comment?
Yeah, and I'll that last point, Councillor Fraser, to try and answer to the best of my ability. The partners around the table will not be signing a legal agreement, but will be signing and joining a partnership agreement. So there'll be quite a bit within that which we haven't yet developed and brought through, hasn't been approved, about the way some of these things will be tackled from a governance perspective. In some ways, it's similar to some other committees where you have differing sort of member voting rights on, in that the chair is the chief operating officer of City of York Council. We'll probably need to have that prior conversation if there is something that is likely to come to a vote, to understand if there's going to be issues within the room that need to be sorted out before they're in the room. Once you're in the room, it is very much that you have that open conversation, and if a vote is needed, a vote is taken. You have the governance mechanisms around what if it's a tie, all that sort of thing, how that vote is registered, and you take that decision. But so, push comes to shove, it will be 5-3 vote or 2-2. Do you see what I mean? So in that sense, I think the mechanisms are established to do this, and part of it is the art of good chairing and prior to a meeting, understanding what is likely to lead to that. We haven't so far in that committee had decisions that have needed to go to a vote, but you have to have that provision. We're not anticipating it to be a regular occurrence, because part of this is about trust and relationship, and trying to build that level of trust that once you're in the room, you're making those mutual decisions in a way that is got the person at the center of it. In some senses, we're going to have to let this play out, and happy, you've already mentioned Scrutiny are going to be interested in understanding how the committee is developing, evolving over the next year or two. So happy to come back and report on that. But just to assure you, for instance, the council's governance monitoring officer has been very sort of closely involved in the production of this, and we have those kind of presence and meetings in terms of legal representation to help us shepherd those decisions.
And I noted that it was also in this that there was progression on this sort of finer detail in the paper. Right, moving on next to Councillor Runciman, please.
I promise to be quicker than Councillor Rose. I want to just say I was astonished at paragraph 61, and I'm really glad that's come up. That's the environmental one. But the question is about underspends and overspends. What happens, thinking about the examples you gave, Peter, what happens if a project doesn't happen in the year that it's anticipated? Does that money carry over from the VCF or any Section 75 agreement to the year after? And what happens if there's an overspend, if it's going to cost more? So could you just tell us quickly about that?
I can certainly, yeah. There will be quite a lot of provision in the Science Section 75 about how these things are dealt with, and Natalie will be able to sort of maybe cover a bit of that. From my perspective, the council's duty to set a balanced budget and to assign the joint committee almost a kind of a pot of money for this is how we make sure that that doesn't get overspent, because in a sense that's the amount of money that we can put in and commission the services from. Even so, at the moment, those are council services that we ourselves are commissioning and funding that can occasionally themselves be either over or underspent. So it's an absolutely genuine and helpful question. The provisions that we need to put in place as part of the Section 75 will be about the risk share of who owns that, but also about the fact that quite a lot of this is commissioning of services where you set an established contract value and you go to the market for it. So while that still means you can sometimes have over and underspends, it is a slightly lower risk because you set a value, you agree that in writing as part of the Section 75 agreement, and then you go out to market to that value. So there's quite an easy way of checking that we're not going to overspend or underspend because the value's gone out. That's it. I don't know if you'd add anything more in terms of those provisions.
I think it just there's a set of draft financial principles that I think were circulated as an appendix. So they've been developed jointly by the Council's Director of Finance and the ICB's Place Director of Finance. Those are in there in draft form and continue to be worked on, refined before we sign the actual agreement later in the year.
Thank you. Next is Councillor Wilson.
Thank you, Chair. I had a really interesting discussion with a resident who had read the public papers, and they were questioning whether this was adding an extra layer of bureaucracy. It's somebody who works within the NHS and was saying, is this just more bureaucracy? But I think from what you said, it sounds as though what you're really looking at is that joint working, reducing some of that bureaucracy. So I was able to talk to her about that. The other question that they asked that I wasn't able to answer, which hopefully you can, is whether it will have an impact on sort of small specialist services. So the example that they used was the York Hull Adult Cystic Fibrosis team, and the fact that it's quite a specialist small team that this board might not have good oversight of what they do. So I don't know if you're able to answer that at all. Thank you.
Well, without knowing the exact details, I can't give an exact and 100% answer. However, specialised commissioning has always sat outside of local commissioning, and there are a number of different specialisms and conditions which are covered by national, regional specialist commissioning teams. And it sounds like the scenario you describe is likely to be part of outpatient and elective care delivered by either a secondary or tertiary hospital, so potentially not even York, might be Leeds, for instance, where that wouldn't be covered by the remit of this. But without knowing the precise terms, I wouldn't like to give 100%.
Yeah, I will just add to that, those types of services will be overseen by the collaboratives, the sector collaboratives, for example. So, for example, the acute collaborative. The place partnership, so the executive committee will have representatives of all those sectors on. So, for example, the chief executive of York and Scarborough Teaching Hospital will link into that acute collaborative and will link to place board. So that gives us a bit more kind of joining up between those two forums.
That's great, thank you.
Back to Councillor Vassy briefly, please, Councillor.
Thank you, Chair. Yes, a short question. In the light of all the discussion, does the Joint Committee have a part to play in working with our academic institutions to unlock innovative practices? I ask relating to adult social care, dementia, chronic illness, etc. And will there be provision made to include such institutions, even if only as observers, to get a sense of what's being done in this area and what can be done?
Yeah, they are members of the partnership and they are represented at the committee. So Higher York and a representative of schools in York are included on the committee.
Good. And I think someone's writing a PhD on it, aren't they? Isn't there someone at university, someone from the University of York? The University of York have a research programme on integrated health systems, and I think recently a PhD student has started. So you're already making those links, and that's specifically around how boards like this function and what their role will be and will they be effective. So they may answer it for us if you can read 120,000 words.
And then finally, Councillor Hook.
Thank you, Chair. Back in the old days when we were first discussing devolution and the combined authority, although it wasn't going to come under the remit of the mayor, there was still talk that we would work with North Yorkshire to try and get the costs down by using our bigger purchasing power. Has that been dropped in the light of this, or is that still happening as a parallel exercise?
It really depends on the type of service that you're talking about. North Yorkshire is not part of our place board, so in that respect, my understanding is that I'm sure there is work going on with North Yorkshire, but not in the sphere that we're talking about today. But then in other areas of services, absolutely, we're looking at what can be done together constantly to try and drive efficiencies and improve services for residents. And myself, Councillor Kilbane and the leadership of North Yorkshire are very committed to that. So I think there's great opportunity.
Thank you all for a very good discussion this evening. I think this paper is a vehicle to make sure that people get healthcare sooner rather than later, which is a point that Councillor Douglas made. There's been a lot of points raised, which James has noted. I'm not going to go through them all. Councillor Vassy, climate emissions to be included in the paper. That's certainly something that will be noted. And to avoid crisis management, it will be challenging to change from acute to preventative. I have noted that down, but I think we all agree that this is going in the right direction and it's worth giving this a try, because there's a lot that's not going on very well and that needs to be rectified. And I think we've got to start somewhere. So unless anybody wants me to mention anything in particular that's been raised this evening. Councillor Hook. Oh, matrix and outcomes, yeah. So that we can measure them. Councillor Moroney, you look like you want to say something? Sorry.
The university can come up with all the methods.
The university can do that. Very good, yes. Why not? I mean, you know, the more the merrier in that people who are experts in this field. So I think we can call it to a halt there, and we can agree that we've discussed the developments in healthcare integration and the opportunities, challenges and implications for the health and well-being of York residents. And we're recommending this goes ahead. Yeah. Great. And it's not quite 7 o'clock. So, Natalie and Councillor Douglas, I don't know if you would like to go. We're going to look at, and Councillor Steels-Warshaw, we're going to briefly now look at the work plan before we finish the meeting. So thank you very much for attending tonight. Thank you. Really appreciate it. So, looking to the work plan, which is on the last page of the agenda. 12th of March 25, Finance and Performance Monitor 3. Now, that's going to be a pretty boring meeting. Sorry, I know it's important, but I think we can bring things forward from the other unallocated items, perhaps. And I think, Peter, you mentioned, and James to me earlier, that it might be possible to either bring the update on dentistry or the healthy weight and weight management to the next meeting.
Thanks, Chair. So the update on in terms of healthy weight management, to just sort of explain to committee what we're looking at here. This year in public health, we're looking at a new approach to healthy weight. To our healthy weight strategy has lapsed, and we are looking as a team to talk a lot more about the sort of compassionate approach to weight, and an anti-stigma conversation, a sensitive conversation about how we talk about weight from a population level, and looking in that to then align some of our public health sort of services and spending more along those lines, and to move away from, I mean, it's interesting that it does say weight management, but actually to move away from the concept of weight management or weight management services, which is a fairly big shift in the city, and not one that is not without its is trickiness, but we want to design it well and design it with Scrutiny's input in terms of those decisions we're making. March, unfortunately, though, does feel a little early to be taking those decisions, unless Scrutiny want very early sort of input and then to bring it back later on. It also, if you're going to do anything about healthy weight, you have to start very young. And so the suggestion was that could be joint with Children's Scrutiny Committee, or in the absence of that, I guess we could look to ensure that children's colleagues are very much represented there, and perhaps invite the portfolio holder for children's as well as part of that discussion. So I just thought I'd give a bit of an explanation of that item. But unfortunately, March is probably early, definitely too early to bring a new approach for approval, for instance.
Okay, so and the update on dentistry then?
That would have to come from the ICB. We can definitely request it. We are 15th of January, aren't we? So we may not get a hugely fulsome paper, but if they are available, we could ask the ICB to update on what they brought the committee probably now a year ago, and we could add some public health, oral health stuff in there, the last year's work of work. There's been sort of movement on that. So I probably wouldn't be able to commit the ICB's time at this moment, but we could make that request, and I could take that as an action out of today's meeting to approach the ICB to see if their dentist commissioners would be able to attend.
It would be, I think that would be rather good, because we had this critical situation in York with the lack of dentists that's affecting everyone, myself included. My NHS dentists have folded. Well, that's my third NHS dentist. So I'm declaring an interest here, but no, I mean, it's just tragic for the city. I don't know if you suggest, so if we will request that, we will look into the other elements. I know we normally do a health and then a housing issue, but I don't think that's going to be possible. So we're going to be going a bit mixed for the meeting in April, if that's okay, Councillor Smaley.
Thank you, Chair. It's just obviously before today's meeting, we heard that the adult social care strategy paper that was scheduled for today's meeting was deferred. I guess a proposal to perhaps defer that paper until sometime in 2028, given that social care is being kicked down the road by the government, and that Baroness Casey isn't going to report until 2028. So maybe we'd like to pencil that in the diary for 3 years' time, 4 years, 3 years' time, and get ready to
I
discuss it
think
then.
we can pencil it in
Yeah,
sooner.
that'd be great.
I think we could share our wisdom with them. Yeah.
On a different issue, Chair, looking forwards, I'd like to suggest that we should bring to this committee in the months not too far down the line a serious discussion on artificial intelligence and health. I think it's clear from what the government's saying that this is an important issue. I think we all recognise it's an important issue. We've got 2 universities in York, and I think maybe a mixture of healthcare specialists and academics to show how this city and its residents and its institutions and its local authorities might potentially engage with all of this to the benefit of the population would be a good discussion to have.
Mm-hmm.
I'm happy to hear what other people think.
Yeah. We can certainly look into what we can come up with to bring to the committee. One thing I was going to say is that we did, James has approached the Be Independent Centre and has sent out a doodle poll so that everybody can tell their availability for us to go for a site visit. So can I just urge all members of the committee to have a look at your emails and so that we can organise something. Right, okay. I think we've covered the work plan. Councillor Rose?
Yeah, I mean, I mentioned pharmacies and work plan stuff at the start, and I guess there are two facets. One, I think it's a fairly neat one, which is if the P&A is going through consultation and then draft, at some point that will come to committee at the right time. But that's a separate thing too. Do we need another conversation around what we want to do, or the scrutiny of broader pharmacy concerns? I think, you know, we've sort of talked about it at length. There's not necessarily a huge amount we can do because a lot of it, I guess, is lobbying nationally for change or for clarity and having conversations with ICB. But if we're going to have this conversation again and again, every time there's, you know, a consultation about a change, and given the comments in the press today and over the recent days from pharmacies about how much they're struggling, the lack of this year's contract, let alone next year's contract agreed at national level, all those bits for me, again, we know that mental health is important, we know that hospitals are important, we know that GPs are important, and pharmacies are a huge part as well.
Yeah, absolutely.
And I think for some of those, they're part of that adult social care strategy and stuff,
Yeah.
but pharmacies is unique. I guess my question is, how long can we leave it? But also, if we brought it sooner than later, what will we actually have to talk about? And that balance I'm not personally sure about.
I don't know if you can fill us in on that.
Well, I would note that the P&A is probably going to need to go through the Health and Wellbeing Board to be approved rather than scrutiny, just in terms of the approval mechanism for that. But it doesn't mean it can't be discussed here. I probably would slightly agree with Councillor Rose that the commissioning and contracting problems which underlie many of the issues we see locally aren't likely to be, well, if they change, it might be worth the conversation, but that if they don't change, we may have a similar conversation to previous ones. But I think as part of the P&A process and part of the writing of that, we could use Scrutiny's feedback and input into that as a mechanism, and then take through the Health and Wellbeing Board for approval. So what we'd probably do is get James just a good indication of what the P&A schedules look like, and there might be a moment in time where a paper on pharmacy and the P&A is the right thing to bring to committee.
Okay, Councillor Velsey.
I'd support what's being said here. There's an irony in it because I think it's a year ago we had a meeting where we had someone from the ICB and a dentist and various other people at the table. And the dentists were very clear that they would be happy to work with the Integrated Care Board, and the Integrated Care Board said the reverse. And then we're hearing today, you know, well, dentistry isn't really part of the integrated care system. having these discussions regularly and making the point, I hope over time will contribute to a growing understanding that integrated care has to include all of that and presents opportunities.
Yeah.
So I agree that we need to talk about it more and hope that we can have an impact.
At the moment, we'll do our best to let you know what's going on. It keeps going off, actually. So has anybody got any urgent business? Oh, yes, of course you can. Thank you very much indeed. Sorry. You've stayed over and beyond. Anybody got any urgent business? No? Okay, I call this meeting to a close. Thank you all very much for attending.